So we don't need to be here unless they ask questions, right, Paras?
No, actually, we're just going to be there in the beginning just to introduce that this is from the College of Physicians. We want them all to become members.
You introduce,
voice.
right? You can't answer, I'll answer it.
We'll just introduce ourselves, and then after that, we'll introduce the chair,
Who's
and then
the
the chair is Dr. Kwan.
Okay.
Dr. Kwan Liu Feng, who is a cardiologist from Hospital Ipoh, and then also the speaker for today. And then after that, the chair will take over and give a detailed introduction about the speaker, and then the chair takes over. Then we can log off.
Since you're all here, since you're all here, what my MTS did, we have the online modules. So when we have the webinar like this, we record it, then we get the speaker to give MCQ, then we put it in the online module and link it to the MMA. So when they answer all the questions, they get 1 point. So you can replay for, I think it's a duration of 1 year. We put it on our education website. You see, not everybody can attend. I'm sure you understand the webinar, especially at 3 o'clock. So ours, the pediatricians, they attend at 5 o'clock. Some cannot attend, the baby crying. So we record it and then we put it on the website like that. Why don't you do that? So you kekal for 1 year, you know what I mean? Yeah.
Maybe what we can do, Dr. Hui, we can have it for them who attend live and for
have
members.
To pay the website guy a little bit money, that's all.
Okay. So our CoPM members, they can log in any time.
Yes, this is meant for doctors. No, we opened it to all RMPs, registered medical practitioners. You must have an MMC number. So it's in fact, it's an educational website,
Okay, that's wonderful.
Idea? Hey, smile like you all. Look at them. Muka dia macam tu.
Maybe stage fright.
No, I set it up just before pandemic hit. So during a pandemic, it was very good, very good. I set it up in early January 2020. So the whole pandemic, we got all that, We put like how to use inhaler, cannot use nebulizer, all put all there.
It's very good. It's very, very good. I think we are recording all these lectures. We have them archived
somewhere. You're recording it. You need a little bit of editing, that's all. And then you need MCQ from speaker. Speaker very lazy to the MCQ. That's what I noticed. Yeah, you got to check it, fella. Isn't it? I'm right, isn't it?
Yeah.
That's the bottlenecking there. Yeah. Okay. Are you
all right? Shall we begin? I think the participants are in. Yeah.
How many participants are there? Out of curiosity, 74. Okay.
All right. Okay. Good afternoon, everyone. Welcome to our weekly webinar organized by the College of Physicians Malaysia. Theme of the month is cardiology. And before we move on, let us welcome Prof. Dr. Paras, President of College of Physicians Malaysia, as well as Senior Consultant AM Physician, to have a few words.
Thank you very much, Mr. Chair, Dr. Kelvin. And also like to introduce my co-chairperson for today, also Dr. Hui from Penang, Respiratory Consultant. Hi, Dr. Hui. Thank you for joining as well. Without much further ado, thank you very much to all our members who have joined us for today. It gives me great honor to introduce our chairperson and our speaker. Our chairperson for today is Dr. Kwan Liu Feng, who is a consultant cardiologist and electrophysiologist, as well as physician from HRPB, Hospital Raja Perempuan Bainon Hospital in Ipoh, Perak. And also, we have our speaker for today, Dr. Chandan Deepak Bhavnani, who is a cardiologist. I would like to take this opportunity to thank all our CoPM members for religiously tuning in every Thursday and supporting this initiative from the College of Physicians. This College of Physicians initiative is spearheaded by the team from Taiping, and we would like to take this opportunity to welcome all members. And for those of you who are listening in but are not members, please maintain your subscriptions to the College of Physicians. It is very important for us to have your support and your voice in all our initiatives. I'd like to hand over to Dr. Hui, who will say a few words as well.
Yeah. Thank you for attending the webinar. I don't think I've been to any cardiology event for a very long time, but it's so nice to see everyone who's logged in this afternoon. I was just suggesting that maybe we could record the webinar and then put it on our education website as an online module so that people who are not able to come in will be able to still listen to it in the future. Yeah. And I hope you will maintain your subscription. I think we're supposed to represent the medical profession and also to look after your subspecialty training, which I think is a very important thing nowadays. Don't you think so?
Absolutely.
Okay. We'll hand back to the chairman for the session to carry on.
All right. Okay, thank you, Prof. Dr. Paras and Dr. Hui. Just a few words about our chairperson today, Dr. Kwan Yu Fong. He's a consultant cardiologist, electrophysiologist, and physician from Hospital Raja Permaisuri Bainon Ipoh. He completed his MD in 2009, MRCP in 2015, and completed his fellowship in cardiology and electrophysiology in 2022. He's also board certified at the international level for cardiac devices and as an electrophysiologist. He has published numerous papers pertaining to cardiology, electrophysiology, presented at national and international level, as well as trained our junior physicians and cardiovascular technologists. Without further ado, let us welcome Dr. Kwan.
Okay, thanks, Mr. Chairperson, Dr. Kelvin. Thank you so much for inviting me as a chairperson. So without further delay, I would like to introduce our speaker for today, Dr. Chandran. He is a cardiologist currently working in Hospital Sedang. So his topic for today is a Holter interpretation. Without further delay, I would like to invite Dr. Chandran.
Hi, good afternoon. Thank you very much for the kind invitation, and I'll get started. So the topic that's been tasked to me is actually Holter monitoring and interpretation. So I'm not sure about the rest of the audience, but a lot of the stuff regarding Holter is automated and we need to decide how to interpret it. So I'll be going into that in some detail, hopefully. So I'm one of the cardiology fellows currently practicing in Serdang Hospital. So a Holter monitor is an ambulatory ECG monitor. It is very useful in the evaluation of patients with symptoms suggestive of a cardiac arrhythmia or a conduction abnormality. So therefore, in a patient who has symptoms, it is an excellent tool to look at patients such as those who have unexplained syncope, near syncopal episodes, episodic dizziness, or unexplained and recurrent palpitations as examples. Regarding ECG monitoring at home as such, there are multiple devices now available. There is the continuous ECG monitor known as the Holter, which is what I'll talk about shortly. An event loop monitor, for example, patch monitor, or an implantable loop recorder. But we'll be focusing on a Holter for today. So as mentioned, a Holter is great in patients who have recurrent and frequent palpitations, because we must understand that the duration of assessment of a Holter is between 24 and 48 hours in most patients. So the patient should have quite frequent symptoms for it to be a useful diagnostic tool. It's also useful for patients such as those who have atrial fibrillation and you want to assess if they have adequate rate control. It's useful for patients who are looking at ventricular premature beats, and of course for heart rate assessment for other conditions such as sinus tachycardia. So this is roughly what a Holter looks like. I think most of us should have seen one. It basically is a monitor. As you can see, it has a shoulder strap and has 2 to 3 electrodes attached to the patient. It captures all the ECG data for a period of 24 to 48 hours. And this is battery operated. So that's the main rate limiting factor, is the battery sometimes only lasts 48 hours. So if it lasts 48 hours, then that's it. It captures 2 to 3 channels of data. It's important to understand that the data captured on these 2 to 3 channels is different from a regular 12-lead ECG. So we cannot localize any beats that you see on the Holter itself. And what's commonly done also is we give a patient a diary. This is mainly to assess symptoms. So if the patient does have any symptoms during the Holter, they can record it in their diary. So a Holter report itself is generated, and this tells us multiple things, such as the total number of heartbeats in the patient during that 24 or 48 hours. It gives us the average heart rate during that time. It'll tell us what the maximum and minimum heart rate is, whether there are any premature beats, be it ventricular or supraventricular. whether the patient has any evidence of tachyarrhythmia or duration of tachyarrhythmia. The duration of the longest RR interval or sinus pauses will also be documented. And also what's very important, at least in our clinical practice, is if the patient has any reported symptoms. So importantly, as I mentioned, the rhythm itself that's recorded should be correlated with the patient's symptoms. And if it's not related, it may not very well be clinically relevant. And a classic example is that of a sinus pause that occurs during sleep, which may not be clinically relevant. And actually, there's data to show that in patients who have a 24-hour Holter, for example, in this study that was done by Zeldis et al., it showed that up to 50% of patients will have a symptom. But unfortunately, of that 50% of the patients, only 10% will actually have a causal arrhythmia. And of that 50% of the patients, 35% of the patients will have symptoms without an arrhythmia. So it shows us very clearly that correlation is very important. It's not just important to identify the arrhythmia, we should be able to correlate it clinically. And also the location of the patients is very important. It's also shown that patients who are hospitalized and have a Holter done during the hospital stay for syncope or pre-syncope, for example, they are more likely to have a causal arrhythmia, showing us that it's important to get this continuous monitoring done as soon as possible. And in one study, they actually showed that if a patient is admitted for syncope or dizziness, some form of causal arrhythmia is identified in up to 50% of the patients if the Holter monitoring was done during the inpatient, versus in a general pool of patients, this can be as low as 6%. So that's pretty much it regarding the utility of a Holter. I'll go through a few case examples because I think that's the best way to illustrate the use of a Holter, at least in our clinical practice. The first is that of a 70-year-old lady. She has moderate aortic stenosis. She's been under regular follow-up. There's no intervention for aortic valve treatment, but her complaint has always been this occasional palpitations. So our first step, of course, was to do a 24-hour monitor. And this is roughly what, this is what a Holter report will look like. It'll give you a quick conclusion, and it'll tell you roughly what the different parameters are, such as you can see on the top left, there's the heart rate, there's heart rate variability, there's ST segment changes, any evidence of supraventricular ectopy, or does the patient have any sinus pauses or any QT changes. What's actually positive in this patient, but not clinically relevant, is the ventricular ectopics that were noted. There are 568 ectopics, which comes to a ventricular ectopic burden of only 0.52%. So look, it then provides you an entire strip so you can identify where the PVC is and determine if this needs further treatment or assessment. And as you can see in the bottommost strip, you can see the one PVC there. And this is seen, of course, 500 times during the 24 hours, but it's calculated at being only 0.5%. So this patient ended up getting, reassurance and nothing further. So the Holter can also tell us if the PVCs are unifocal or if they're multifocal in nature, because that will change the management. It'll also tell us the locations of the premature beats. So the burden is important because I think all of you will see this very commonly. These numbers are quite arbitrary, but correct me if I'm wrong. Low burden is often defined as less than 1% of PVCs during the day, which amounts to roughly 1,000 PVCs per day. And intermediate burden is between 1 and 15 or 1 and 20%, depending on which guideline you follow. And of course, a high burden is more than 15% or 15,000 PVCs per day. And of course, further intervention, if medical therapy has failed, such as catheter ablation, is indicated in patients who have an ejection fraction that has dropped, such as that of less than 50%. Someone who has a very high PVC burden, but of course, this is a case-to-case basis, especially if medical therapy has failed in the first instance. And most importantly, in the patients who are symptomatic, and we feel that the symptoms are due to the PVCs themselves. So moving on to the next example, is that of a 75-year-old patient, diabetic hypertensive, who comes in with a left-sided body weakness, slurring of speech for 1 day. Clinically, as evidence of a partial anterior circulation infarct, and a CT brain shows an acute MCA infarct. So his resting ECG, as you can see here, is quite unremarkable, and the patient's in sinus rhythm. So we proceeded with an echo, and the echo showed a normal LV ejection fraction, no obvious valvular lesions. So the initial treatment instituted at the hospital was, of course, swallowing assessment, physio, and medication-wise, single antiplatelet with a statin, with optimal blood pressure and diabetic control. We did plan for an outpatient Holter to see if we could identify anything. And true enough, if you could look at his Holter, there were runs of atrial fibrillation, defined, of course, as an irregular baseline, irregular pulse with absence of a P wave, and the runs were all well over 30 seconds. So the question is, how did this Holter change the clinical management for this patient? And the answer is that because the patient had an MCA infarct, a repeat CT was done at 14 days, and his antiplatelet therapy was stopped and switched to an oral anticoagulant after discussion with the neurology team. So we have plenty of evidence for a Holter use post-CVA, and that too using a Holter in the immediate after event of the CVA, so you can have the highest rate of detection. So there's one study that we looked at, which was quite useful, and I think it's quite important to highlight. It was done just last year, and it looked at patients who were admitted with stroke or TIA to a hospital in the Netherlands who had sinus rhythm on admission. And these patients received prolonged Holter monitoring for up to 14 days, because the guidelines suggest that in a patient who is low risk, that prolonged monitoring of 48 hours might be useful. But this study showed us that even longer monitoring with a Holter may be useful in this group of patients. And they found up to 10 cases of incidental atrial fibrillation. Although 7 patients were detected in the first 48 hours, 3 patients required a further 5 days of monitoring, showing us that, maybe a prolonged Holter monitoring might be useful in this cohort of patients. So next example is that of a 50-year-old male. A patient has anterior STEMI, for which a primary PCI was done. An echo done 3 months later shows an ejection fraction of 40%, and it shows a mid to distal anterior wall is akinetic. So he was already on optimal heart failure therapy at this point, but he did have a complaint of occasional palpitations with pre-syncopal episodes. And we did a Holter, and of course, it showed us runs of ventricular tachycardia. In fact, one of the runs was just over 30 seconds, and it's surprised that this patient did collapse as a result. Now, looking at the clinical scenario and what we found from the Holter, we admitted him to the ward and, of course, offered an option of an ICD for prevention of sudden cardiac death, and he was keen, and this was done shortly thereafter. Next example, just a couple more examples, just for me to highlight how we use Holter in clinical management in our center. We have a 75-year-old lady. She has these occasional palpitations, but no syncopal episodes at all. So basically, Holter is done for completion of workup, because we receive many patients for assessment of palpitations. Her echo was unremarkable, but we noted this at 3 a.m. So she's sleeping during this time. She has no recollection of the event at all. But there's a pause of 3.4 seconds, which of course is long. But it's important to take in the clinical context. And this patient was sleeping and had no symptoms of bradycardia-related events. So when we talked to her again, she had no dizziness, no syncope. So we gave her the option of watchful monitoring, and she was very agreeable and keen on that. And actually, she's been well and well since, with no symptoms, under regular follow-up under us. Lastly, a patient, very similar timing of events, but a completely different approach. This is a symptomatic lady who's 84 years old, who has dizziness for the last 4 months. She has a preserved LV ejection fraction, but she's referred to us for further assessment in view of the dizziness. So her echo and things like that were normal, so we decided to do a 12 to 24-hour Holter because she was quite symptomatic. And if you look through the Holter, this is again a summary of the Holter. No real ventricular ectopics or supraventricular ectopics. But if you look at the minimum heart rate is 45 and the maximum heart rate is 112. And what we also noticed at 2 o'clock in the morning, surprisingly, is she had runs of a complete heart block. So given the fact that this patient was symptomatic and we couldn't find any other reason for the symptom, we attributed the symptoms to this complete heart block, which she must have been having, causing her to be dizzy. So we advised for a pacemaker, which she agreed for, and it was implanted, and she's been very well ever since, actually. So I've talked a lot about Holter, just 1 or 2 slides on a prolonged monitoring. So we use this in our hospital. I'm not sure if we use this in other centers, unfortunately. But this is a patch monitor. We put this on patients who need prolonged monitoring. So this patient is another patient who had a post-acute myocardial infarction, but had multiple ectopics and very frequent ectopics. So we wanted to see if he was at risk of a VF or VT. So we kept him in the hospital for 7 days and just continued to monitor him. And as you can see, this patient had analysis done for over 6 days. And despite analysis for such a long duration of time, all we could identify were PVCs. We didn't identify any runs of ventricular tachycardia. So actually, we were quite happy with this patient to discharge home and continue optimal medical therapy. So basically, in conclusion, for me, at least for me in clinical practice, is when we do a Holter, we need to know what to do thereafter. So I look at two things. One is whether the patient has symptoms and whether we can identify ECG abnormalities, be it at rest, be it at exercise, or be it during the Holter. So if we find that the patient has symptoms and we find that the ECG has an abnormality that we can attribute to the symptoms, then of course it's fair to treat this patient appropriately, and no further diagnostic testing is usually needed. If the patient has symptoms but has no corresponding ECG abnormality, then we need to look back and see, are these symptoms significant? And if they are, should we decide to do a longer monitor? And if we think no, we don't need to do a longer monitor, we don't think the symptoms are significant, then the diagnosis is unlikely cardiac. However, if the patient has no symptoms and has no ECG abnormality during the Holter monitor, I think we have to make the decision to decide whether we want to extend the monitoring on an individual patient basis. With that, I thank you very much for your time.
Okay, thank you, Dr. Chandran, for the informative presentations. I think the example shared by Dr. Chandran is very relevant in our clinical practice. Anyone have any questions? Feel free to ask. You can put your questions in the Q&A or in the chat group. So just a few comments to the audience here. So when we want to order the Holter, I know there will be a different durations. Either it's 24 hours, 22 hours, 1 week, or 2 weeks. So usually the duration order, it depends on what you want to look for, and also the duration, the frequency of the symptoms. Just for example, if you're looking for a PVC burden and you know that the patient having a PVC most of the time, so probably a 24 hours Holter will be adequate. Another example, another extreme, if you're looking for a patient with a paroxysmal AF and patient has no symptoms, you just want to detect, you want to see whether there is AF and when patient presented with a stroke. In this sort of scenario, you know that you do 1 day, it won't be adequate. So whether you want to do a prolonged Holter and how long you want to do, up to 1 week or 2 weeks, or even some patient we put an implantable recorder. So the point I want to give is when you order the duration of Holter, it depends on the symptoms. Example, patient tell you she has palpitations once every 2 days. So probably you order a 72, you order a 1 to 3 days Holter is sufficient. Or another scenario, patient tells you I have palpitations once every 6 months. You know that you order 1 day Holter, it wouldn't be sufficient. So a lot of time, I think it's all depends on the clinical presentations. Then only you make a judgment how many days, how many durations you want to order for the Holter. And the second point I want to make is, if possible, you know that our Holter, there will be usually at least 2 or 3 channels. So if possible, try to use multiple channels. The reason is if you only use one channel recording, sometimes when there's artifact, you're not sure whether this is a true arrhythmia or this artifact. At least you have a second or third channel, so you can differentiate the artifact well. So I think these are the 2 points I want to make. Any questions from the floor? So one question.
Should we go to the Q&A? There's one question regarding a high PVC burden and a patient who is asymptomatic. So I'm not sure about your practice, but here it's really defined by patient symptoms. And if not, it's really looking at the ejection fraction of the patient. So we find that the ejection fraction is going down and we think that the drop in ejection fraction is due to the PVC, then a catheter ablation, if feasible, is a really fair option for this patient.
If you look at the guideline from European Society of Cardiology, indication for catheter ablations for PVC is two. One is symptom. This patient have a symptomatic PVC. There's a evidence to do the ablations. Second is when the PVC burden is very high and causing a poor LV functions, or we call PVC-induced cardiomyopathy. Then these are the two indications we can go for ablations. If let's say there is high burden without any symptoms or LV functions normal, whether you want to proceed for ablation, that's under 2B. It's case-to-case basis. At least a clear indication to ablate high PVC burden. First one is symptomatic. Second one is PVC-induced cardiomyopathy. So I think this is what guideline said from European Society of Cardiology, the ESC guideline.
Yeah.
Okay, second question is there any role of Holter in SVT? Okay, if you can capture SVT, patient came to you, SVT, and you revert with IV adenosine, you don't need any Holter. You already got the abnormal ECG in front of you from the 12 ECG, which you can see all the rhythm, abnormal rhythm for all the 12 lead. So you don't need another Holter to further evaluate. You can refer straight for ablations or any further management based on the 12 ECG you capture before when patient presented with SVT. Okay, so far there's two questions. To proceed, Holter. Okay, there is another question. Does all patients with PVC or PAC need to proceed with Holter test regardless of symptoms? Okay, I think this will be a separate questions. So I talk about PAC first. If PAC no symptom, you don't need Holter. PAC, you only require treatment is symptomatic. And also, what are the points that PVC telling us that if you see a patient with a frequent PAC, we also tell us that patient has a risk to develop atrial fibrillation in future. With that, if patients no symptom, you don't need any Holter for the PAC. You only treat PAC when there is symptoms. But for PVC, you need to quantify the burden. If you see a PVC, you need to quantify the burden. Okay, next question. Is there any value to re-evaluate or repeat the Holter after starting medical therapy for symptomatic PVC? Yeah, I think you need to. At least there is objective documentations. If let's say before you start treatment for PVC, the burden is 40%. After starting, at least you have evaluations to show that the patient improved in terms of symptoms and also PVC burden. You need another Holter. Probably it's not urgent. You can do it even later. Maybe just an elective appointment will do. So PVC quantification, no symptom, unifocal, still need Holter. I think the more important is the echo. At least echo will tell you whether this PVC burden is high or not. But my personal practice, I still need a Holter to quantify the PVC burden, because the burden also can tell me, even though no symptoms, if this is a high burden, example more than 20%, at least I know that patient have a risk to develop heart failure in future. Then I will be more vigilant to monitor the symptoms and also the heart failure by doing a echo surveillance. Okay, any significant clinical indeterminate origin? That one is more for EP when we want to do ablations. If you want to look for the origin. I don't think if you are from primary care or medical department, the origin may not be so important. It's more for us to determine the origin because we want to go for ablation. At least we know where to ablate. But of course, another point I want to tell is if you can differentiate whether this is outflow tract or non-outflow tract PVC, it helps us a lot. At least we know outflow tract PVC most of the time is benign, especially in the young patient with a normal LV function. So probably the clinical importance that you can differentiate whether it's an outflow tract or non-outflow tract is adequate. You don't need to be very particular where is the origin. So any question from the floor?
I heard something interesting. The speaker was saying that you must do a prolonged Holter for the ischemic stroke, and you might find AF. Now, do you really recommend that we screen all the ischemic strokes this way? How do you choose? Because that would seem like a very large number that you have to screen.
So I think we can't do that in our clinical setting. I mean, even though guidelines suggest for
That's what
prolonged,
I
this
was
is 48
thinking
hours.
when you showed the slide that, you know,
Yeah.
it looked pretty huge workload. So how do you rationalize that? How would you recommend? Because you put that up, you know, you said that you could carry on screening and you would, after a prolonged time, maybe find some AF, and then you have to change the management. Yeah.
Yeah, but if you look at the slide that I put up as well, is after 48 hours, the number that you pick up drops significantly as well. So I think it really is a case-to-case basis. I would think
But
48
even
hours.
if you screen everyone for 48 hours, that seems to me a lot. Yeah, I'm sure you haven't gone to the general ward and said, look, send me all these stroke patients and I'll hold. I'm sure you haven't done that. So
I think in our current state is difficult to implement. I agree.
But at least if let's say those patients without cardiovascular risk, probably we have to concentrate on that. Maybe we'll focus on those group of patients without cardiovascular risk. Then maybe we can focus on this group of patients to do a Holter to detect any AF.
Is it going to be in the stroke guidelines, do you think? Because that one, I think the neurologists have gotten hold of it, right? They're very great on stroke and how you thrombolize people and all that. And then after that, where's the source of the thrombus? You know what I mean? Yeah. So is it there or not? Or are you going to work on them? You see, I don't know whether there are any neurologists in the audience. I really doubt it. But then they should know about that too, right? I'm a gadfly usually. I will throw things in. Yeah. No neurologist? I think they're not going to admit to it. Okay. But I'm a respiratory physician. So last time I used to go and solicit to get patients. Like if you get a nebulizer in the casualty, obviously you're not well. So you need to come and see me. I'm sure you're not going to do that, right? You got a stroke. And then you might have this AF, which I'm going to find after putting a Holter on you for 2 days. You're not going to go to the stroke ward and solicit like that, right? It's soliciting, yeah. Crazy, right? Yeah. Okay. Yeah.
Okay, is there any questions from the audience? So far, I do not see any new questions. All right. So, Dr. Kelvin, should we close the sessions?
Yeah, if there's no further questions from the floor, I think we can end our session now.
Okay, thank you so much, Dr. Chandran, for the informative presentations. Also, thank you, Dr. Hui, for your opinion. I think we shall end the session now. Thank you so much of all the audience for your participation. Okay, so we'll see you again next Thursday at the same time for other topics. Okay, thank you so much.
Thank you.